So first of all, good afternoon, good evening, everyone, and welcome to our first Global PPH Expert Symposium. We're delighted to be joined today by so many delegates from around the world covering over 30 countries. My name is Andy Sutcliffe. I'm the Managing Director for the CELOX PPH organization. I'm also joined today by a few of my colleagues, Lindsay Rogers, Sarah Boyer, and Sarah King, who will be helping with the meeting facilitation. Since we received CE marking under MDR just over 2 years ago, following 12 years of extensive clinical evaluations and publications, we've had an unprecedented level of demand from clinicians around the world to hear more to help with the significant challenges associated with PPH. And today, we now have approval in 31 of those countries for CELOX PPH. And this meeting really is about drawing together some of those experts who have been a key part in that journey over the last 10 plus years. And for them to share their long-term clinical experiences in the management of PPH and provide further clarity and insight into best practice. So as we go forward, please feel free to add any questions or discussion topics in the chat, and we'll collate those and propose any questions to the speakers at the end of the presentation sessions. A couple of housekeeping topics. Firstly, you're all muted, and we'll be doing the Q&A through the chat function at the end. And second, we would appreciate if you could turn your videos off to ensure adequate bandwidth for the meeting, as we've got quite a few hundred delegates that will be joining the meeting over the next couple of hours. Before we start, I'd like to throw up a couple of short questions really to gauge the audience response and who we have in the meeting. Okay, so I'm going to throw those up on this screen, so you should be able to see some of the results. Can you see that come up on the screen, Prof?
Yes, I can see.
Good, okay. So we have about 71% obstetric consultants, clinicians, OBGYNs, PPH cases per month. Again, a kind of wide distribution, mostly around the 3 to 5, 0 to 2, some on the 11 plus, so some significant volumes that we're seeing across the different maternity clinics. Deliveries per year, again, a wide distribution, mostly around the 1 to 5,000 per year. And as expected, I guess with current standard of care, the Bakri or the balloon tamponade got the largest share with about 81%. We've got hemostatic tamponade, packing with swabs, sutures, embolization. So again, a reasonable distribution. And at what level of blood loss will you typically intervene? Again, quite an even response across the different blood loss levels from 500 to 1,000 and 1.5 to 2,000. Thank you very much for those. So without further ado, I'd like to start by introducing our moderator and chair for the meeting, Professor George Sade. So Professor George Sade is a professor and chair of obstetrics and gynecology, associate dean for women's health, and EVMS Foundation Chair for Women's Health at Eastern Virginia Medical School. He's a past president of the Society for Maternal Fetal Medicine and past chair of its Health Policy and Advocacy Committee. He's also editor-in-chief of the American Journal of Perinatology. So, Professor, thank you again for joining us today and for moderating the CELOX PPH Expert Symposia. And with that, I'd like to pass the floor to you to kick off the meeting. Thank you very much.
Thank you, Andy. So, thank you, Andy, for including me with this august group of experts who have really put CELOX and on the map in obstetrics. And I really congratulate you and your team for taking on this important issue and bringing to the forefront a new method, and I think a more effective method of managing postpartum hemorrhage. Just a few words and few slides about the importance of postpartum hemorrhage. I'm sure that many of you here already know these things, but it's good to frame the discussion for the future talks. The definition of postpartum hemorrhage varies by country, by professional organization, and the American College of Obstetricians and Gynecologists, even a few years ago, changed their definition. No matter what definition you use, I think volume of blood loss is just too rigid. It's really what happens to the patient, what morbidity and mortality is the result of postpartum hemorrhage. But if you want numbers and definitions, you can think of postpartum hemorrhage defined as primary, which occurs within the first 24 hours after delivery, or secondary, which occurs later. And the various cutoffs that have been used were 500 cc's for a vaginal delivery in the first 24 hours, or 1,000 for a C-section in the first 24 hours. As I mentioned, the American College of Obstetricians and Gynecologists changed it to 1,000 for both, or any hypovolemic changes resulting from postpartum hemorrhage. Now, why are we here? Why are we concerned, and why do we need something to do something about it? It is the postpartum hemorrhage really affects quite a lot of patients that we see. And this number is increasing and also different for different countries and different practices. But on average, 10% of women who give birth are affected by postpartum hemorrhage, leading to about 14 million patients a year, which is quite staggering. And about 20% globally of all maternal deaths are associated with postpartum hemorrhage. And that's a conservative number. And if you look at the total number, 80,000 women die from postpartum hemorrhage per year. That's again a very sobering and staggering number. And most of these deaths occur in low-income country, where the postpartum hemorrhage is the most common cause of maternal mortality. And even when patients survive the postpartum hemorrhage, they also have other morbidities. So the maternal mortality is only the tip of the iceberg when we look at postpartum hemorrhage and add to it the severe morbidity and lifelong disability. Now, every 4 minutes, a woman dies from postpartum hemorrhage. That's again a very high number of patients. And if you think of the total births per year across globally, you can see that most of these births and deaths resulting from postpartum hemorrhage occur in low to middle income countries. And why is that important? The important for at least for us and for this topic of CELOX is that, as I saw in the responses to the questions earlier, a lot of you use balloon or some other device to address postpartum hemorrhage as a second-line treatment. And the problem with these is they require expertise, training, and resources to use them. And most of these are not available where they're mostly needed. If you can see this number, about the device market is mostly in the United States and Europe. And the other countries, low middle income countries, don't have access to these, or if they do, they cannot use them where they're mostly needed. So more than 80% of maternal deaths, at least by data in the United States, are preventable. And when the CDC defines preventable, they use any intervention that could have prevented the maternal death, including social interventions. And the reason I am mentioning this is because that's important for low and middle income countries. So there is really a need for early intervention and accessibility to clinical and cost-effective options. And that's where I think CELOX has a role to play. Now, we talked a lot about mortality, but this is the tip of the iceberg. I think the severe morbidity and other morbidities and lifelong implications of postpartum hemorrhage are as important and maybe even more important because they affect more women than the mortality. These are just a few of the morbidities that are associated with postpartum hemorrhage. Anemia globally affect 36% of women, at least in 2019, and this number is increasing. And anemia has lifelong implications, not just peripartum. 6.8% of of patients who have postpartum hemorrhage require some type of surgical intervention, and many of these are reoperations. And blood transfusion is about 1/3 of postpartum hemorrhage require blood transfusion. And many of these transfusions may not be available in low middle income countries. And then you have the length of hospital stay, which is quite important for us in the United States. And that length of hospital stay keeps increasing over the years, mostly from postpartum hemorrhage. And a lot of the increase in the hospital stay from postpartum hemorrhage is associated with other comorbidities that are resulting from the hemorrhage, like wound infection and sepsis. Now, just a few words about anemia, because I think this is a appreciated complication of postpartum hemorrhage. Most of the time we think of anemia as something we can treat, but we also know that anemia is not adequately treated in most patients, resulting in a cycle of anemia for future pregnancies as well as future health of the patient. And there are many studies that also show, including the Woman 2 trial, that anemia is a risk factor for postpartum hemorrhage, not just need for transfusion, but also because the uterus may not contract adequately. So anemia is actually quite common and has a lot of implications that were appreciated in the past. So for all of these reasons and many more that I cannot get into, I really thank Andy and the CELOX team for putting together this conference. And I thank so many of you, more hundreds of you who have joined, because I think there is a great opportunity here to impact this important issue in obstetrics. So now I'm going to turn over the presentation to Andrew Hogarth, who's the Director of Research and Development at CELOX. And then we're going to hear from experts in the field. And these experts are really, in my opinion, and from my background, who have put CELOX on the map in obstetrics. So you're going to hear from the people who really started using the CELOX and have the best expertise in this regard. So I'll come back and introduce each of them after Mr. Hogarth's presentation. Andy?
So thank you very much, everybody, for allowing me to speak around the science of CELOX. I'm Andrew Hogarth, Director of Research and Development at Medtrade. I've been with the company for 15 years now. This technology dates back to at least 20 years, so it's building on a very strong foundation. If we look at what CELOX is, CELOX was originally developed for battlefield situations to stop moderate to severe bleeding, not only in the battlefield, but also in civilian medical emergency arenas as well, so paramedics. And it was really developed to control the bleeding where traditional strategies didn't work. So direct pressure alone was ineffective. So creating that hemostatic technology along with the gauze allowed us to pack those wounds very quickly, stop the bleed and save a life, and allow that person to get back to a surgical environment where the next stage of treatment could occur. So this presentation is really going to focus on what the CELOX technology is and how it's effective in all situations. So what is CELOX? Well, CELOX comes in a multiple variants historically, ranging from granules that are applied directly into the wound to granules coated on different gauze types, right through to our newest addition to the range, where we actually include a bioadhesive to make sure it stays in place during that evacuation of the patient. And we've recently, in the last 12 months, gathered a prolonged field care claim, which means that this device has been shown to be effective for prolonged field care, which is over 3 days. Traditionally, a lot of the mineral-based hemostats that activate the clotting cascade don't work well in trauma situations. You quite often have coagulopathic conditions, or some of the civilian patients are on blood thinners. So CELOX is derived from chitosan, which comes from shellfish. And the way it works is it forms a physical gel, and we'll go into that in a bit. And in doing so, it works independently of the clotting cascade. So in those conditions where the patient's blood is compromised, CELOX will still work. And that makes it very effective, not only in sort of standard conditions, in those compromised conditions, but also is designed to work in very austere environments as well. So, we test it as low as -20 degrees Celsius up to 60 degrees Celsius, and show that it can have that range of effectiveness irrelevant of where it is in the world. The next slide is just an overview, really, of all the different types of clinical evidence that has been published over the last 20 years related to the use of CELOX in very different environments. And I think it's this scientific data that led some of the key speakers that are going to speak today to using this technology in the area of postpartum hemorrhage. So again, it's got a lot of usage, both in that civilian emergency medical services, all the way through to on the battlefield, where other interventions are not there. And so the whole survival of that patient related to blood loss is dependent on CELOX. We'll break the CELOX down into, where does it come from? Well, we actually source our chitosan from shrimp. So that's the base source of that, and we source it from the North Atlantic. We then take that shrimp, we take the shells from the shrimp, and we convert it into chitin. From chitin, we convert it into chitosan, which I'm sure most of you on the audience today will have heard of. And then we modify the chitosan, particularly around the amine group, to give it its specific properties, which you know as CELOX. But I think it's important to realise that during this process, we can't just look at efficacy in isolation. We've got to look at that safety profile as well. So I'll look through, the processes that we undertake just to give you a bit of background and allay some of those fears, particularly around shellfish allergies. Is during the first stage, we fully remove the meat from the shell. It's pure the shell part that we're looking at. And then we go into two key processes, demineralization and deproteinization, where we're trying to strip all the proteins out of the shells as we move it into the chitin aspect. From that, we then deacetylate. These are very aggressive processes that give us the performance that we need, and then through to sterilization. So what's the result of those different steps? Well, one is that initially we remove tropomyosin, and that's the protein associated with shellfish allergies. The next steps make sure that there's no remaining viruses, so we've got full viral inactivation as required by the regulations. And the process is also eliminate and remove bacteria and endotoxins, such that they're at safe levels and we don't see any clinical effects. And given the post-market surveillance we've had over 20 years, we haven't seen any associated incidences of reactions associated with any of these materials. Looking at the screen now, we're going to talk through what's the difference between chitosan and CELOX. And there is a big difference. Not all chitosan is the same, and it's what we do with the chitosan that converts it into the CELOX. So you'll see in the top right-hand corner, The test tube on the right, which has remained a gel, is CELOX. The test tube on the left, which has lost its gelling performance, is chitosan. So chitosan, when it absorbs fluid, kind of creates wet sand is a good description of it. It doesn't gel because it's chitosan is actually insoluble in water. It needs an acidic environment. So we convert the chitosan into the CELOX, which is a salt form of the chitosan, so an acidic form. And it's this acidic form that gives it its gelling profile. And it's that gelling profile that creates that pseudo clot around the bleed site and enables it to stop the bleeding. So there's very key differences between CELOX and chitosan. You can see on the bottom presentation that what we've done is we've applied the CELOX granules over the fluid. That will allow the fluid to absorb into the first sort of 50–60% of the granules. It will form a gel, and then when we invert that test tube, the gel remains in place, mimicking how it stops the bleed in youth. Again, you know, this formulation and this technology was based on granules. So the granules, in terms of their mode of action, will absorb the blood. They will form a viscous gel which plugs the bleed site. There is a level of mucoadhesion that takes place, which makes sure those granules have a very small wet stick to the surrounding tissue. This is important such that it doesn't move off the bleed site and cause rebleeding. And it's also cationic. So it'll attract the anionic red blood cells underneath it to help create an environment that's really conducive to the body's natural clotting system. So that's how the mode of actions for the granules work. As you know, with CELOX PPH, the granules are then coated onto a gauze, and it's very much the similar mode of action. So when you pack that gauze into a femoral artery bleed in a military situation, or in this case, into the uterus, the gauze becomes soft and compliable and sort of molds around that bleed site, allowing the granules on the gauze to absorb the blood and create that gel viscous-like plug. The benefit of the gauze over the granules is you get multiple layers of that gel. As you pack the gauze, multiple layers form. As the blood gets absorbed into the gauze, it forms multiple layers of that gel, which gives it a very good barrier to bleeding and prevents the bleed. Again, it's got slightly mucoadhesive, nothing too major that you've got any issues on removal, but just enough just to prevent it moving off the bleed site as the patient may move or reposition their body. Again, it's got that cationic nature, so adhering it to the gauze doesn't lose that property, such that it's creating that conducive environment for natural clot formation underneath. The pictures in there are the one on the right is showing a standard hemostatic gauze that relies on the clotting cascade, and this is a traditional weakness in these dressings. When the materials are put in contact with the blood can actually soak through, and this is what's demonstrating on the right. So you get this continual flow of blood through the gauzes and can create rebleeds. On the left is CELOX, and you can see there that we've applied the fluid, and what it's done is it's not leaked through. So this is where the granules are gelling and forming that plug, not allowing the blood to penetrate through the dressing and create a natural bleed. Now, many of you might be asking, is this just down to purely absorbency of the dressing? Is it just that dressing's got more absorbency, it's absorbed all the blood? If I move this along slightly, you can see that we actually add more blood or fluid to this, and it's not absorbency. It's caused a physical gel clot, which prevents any rebleeds. So again, we're not allowing any fluid penetration through that dressing, again, helping create an environment that's conducive to the body's natural clotting system. Again, this works really well in all areas, particularly austere environments, but also in the hospital environments as well. So just regarding the science, these are a few studies that we've undertaken related to CELOX. So again, I mentioned that we've got the prolonged field care. We show that that gel stays in place even in the presence of lysozyme, which will break down the gel for up to 3 days. We've done a lot of work around biofilm prevention, and you can see here that when we've tried to grow up biofilms, related to infection, CELOX is very good at preventing biofilm formation. And again, I think that's demonstrated below. So you can see the green viable organisms in the untreated control on the left. In CELOX, it's literally black. That all the bacteria haven't been allowed to grow up as a biofilm. And then the other thing that we use CELOX for is we use it after post-sharp debridement, and we see a very different tissue viability after the use. So again, it helps promote that tissue viability that helps wound healing, so helps the body naturally create that nice wound healing environment. In conclusion, CELOX was designed for the battlefield. It's a small footprint. It can be carried around in bags. It works on anticoagulants and in coagulopathic conditions. It's very fast acting, only requiring 3 minutes of compression. It's very stable if the patient moves, so there's very low risk of rebleed, and it works independently of clotting factors, so clotting cascades. So it can de-risk that potential failure mode if the patient has got compromised blood.
Thank you, Andrew. This is great, fascinating to
Thank you
know
very much.
the biology behind it and how it works. It is my honor and privilege, distinct honor and privilege, to introduce Professor Henrich. Professor Henrich is a professor of obstetrics, director of Department of Obstetrics, and head of ultrasound division at Charité University Medical Center in Berlin. For those of you who may not know, the Charité Department of Obstetrics is the largest obstetric facility in Germany, with approximately 5,000 deliveries per year, with a high proportion of high-risk pregnancies and deliveries. And Professor Henrich has given us so much evidence around postpartum hemorrhage, as well as other obstetric and ultrasound practices. So I'm really looking forward to his presentation. Professor?
So thank you very much, Professor Sade, for the friendly introduction. So my name is Wolfgang Henrich. I'm the head of the department in Berlin since 14 years. And when you are head of a department, you're responsible actually also to deal with all catastrophes and also bleeding catastrophes. And it was in the first years of my chair, it was really sometimes at night, especially at 2 o'clock, very difficult to run into the hospital and to try to solve the problem. And so since we introduced CELOX 2016-17, I definitely can sleep a lot better because my team and all the consultants on duty are familiar with this technique, which really helps us to avoid a lot of catastrophes and bleeding complications. So Professor Sade showed in his very nice talk that we have really a worldwide problem. And when we sit here, every second, 4 babies are born, 1 per C-section, and the bleeding is a major cause of the problems worldwide, also in our hospital, because we have more elder ladies becoming pregnant. We have more multiples, more patients after previous uterine surgery and preeclampsia, obesity, etc. All these are causes for the increasing rate of PPH. And you already mentioned the problem of anemia, so I can go fast over this. Just to mention, if you have hemoglobin level of 7 or less, you have a 6 to 7 time-fold risk for PPH, and this is due to the lack of red blood cells, which carry the oxygen, and without oxygen, the muscle can't contract, and therefore the increase of the bleeding problems in this cohort. So you can anticipate in a lot of patients that they will bleed, like in a patient here with a severe varicosis, the multiples, polyhydramnios, And if you do a second trimester screening, you can see in the uterine artery flow, shoulder and deep notching and slow interstitial flow. You know that these patients are candidates for preeclampsia, abruption of placenta, preterm delivery, and C-section. And the macrosomic fetuses are at risk for atony as well as preterm rupture of the membranes. You can here see by ultrasound the bladder and the uterus and the moment where the amnion sac ruptured. All the patients with placenta previa and lower uterine segment bed bleeding are patients at risk, as well as the placenta accreta or a PASS, placenta accreta spectrum patients, which are at high risk for bleeding. Also, myomas or fibromas or intrauterine demise after long-term induction of labor or trauma patients are patients at risk, as well as patients with uterine scar dehiscence, as you can see here by ultrasound. And when we opened the belly, the uterus was already open, and we are very glad to do a C-section and not a trial of labor after C-section. So ultrasound is a great tool to anticipate the problems. However, the majority of problems occur under delivery in the patient without risks. Just to mention again, placenta accreta, increta, pacreta patients, there's a special role for me for the gauze, but we will come later and maybe also in the discussion where the limits of our expectations are for the gauze in these patients. So after we using the medical drugs, syntocinon, tranexamic acid, or capitocin, or sulprostone as our major drug to contract the uterus. In mild bleedings, we are using misoprostol for moderate to mild bleedings. But when these medications fail, we have to perform another treatment option. So before I come to the options, I want to show you that you have to clarify the bleeding site. If it is an atony bleeding or placental residual bleeding, you can see here by ultrasound the delivery of a normal placenta with an empty uterine cavity. And I would recommend to encourage the young assistants and trainees to get familiar with the normal delivery of placenta and normal finding after a regular delivery. You can see here how nicely ultrasound images correspond with MRI images. We had taken these images from the only and one human birth under MRI at the Charité. So if you have to remove the placenta, we are doing this under ultrasound guidance, also to make sure that we don't leave any remnants behind. And when we have to perform curettage, we also do this under ultrasound guidance to be sure not to perforate and to make at the end of the procedure a picture of the image of the uterus for the documentation that you have performed it adequately and that you removed all the placenta tissue. So the next step, if medication fails, if you are sure that you emptied the uterine cavity and that you may repair lacerations of the birth canal, the next recommendation from the WHO, from the American College of OBGYN, and for the Green Journal is to use the intrauterine balloon tamponade as an appropriate first-line so-called surgical semi-invasive intervention. So interestingly, before balloon tamponades were used, already 856 in the Principle of Practice of Obstetrical Medicine and Surgery, the gauze packing was recommended as a measure to stop the bleed. So let me talk about shortly the alternative, and which is nowadays mainly recommended, the balloon tamponade. You can visualize this by transabdominal ultrasound to make sure that you have the right position here, the transvaginal approach of ultrasound. But you can see that especially it is difficult to position a balloon in the upper part of the uterine cavity. However, fortunately, the majority of bleedings come from the lower uterine segment. For instance, in lower uterine segment atony or in placenta bed bleeding after placenta previa removal. However, especially after spontaneous delivery, after full dilatation of the cervix, these balloons very often slide out and you have a lot of failures. Beside these technical problems, the overall success rate in the literature is so far approximately only 85%, so 15% failure rate. We used the balloon till 2016, 17, and we removed it typically when it was efficient in the first hours after 24 hours and with relatively good further long-term results. Another option to stop the bleeding is embolization. You need the facility, an experienced radiologist. You have several risk factors and complications, allergies against the contrast media, bleeding from the puncture site, dissection of the vessel, or failure rate of approximately 10%. And you can only transfer a more or less stable patient to the radiological department. You cannot transfer an unstable patient because this would lead into much more trouble. So it is also a limited option actually in the daily work. So the next more invasive treatment for bleedings are sutures. However, with sutures, you need an open belly. This is typically possible to use during a C-section because you do not want to open the belly after spontaneous delivery. So mostly these sutures are used during C-sections, and you can combine the Pereira suture, for instance, here shown, or here a B. Lynch suture. This is Professor B. Lynch. He visited us in our hospital and he showed us how to use the method adequately. And you can see here that we combined suture techniques with balloon. However, these compression sutures have also their limitations. Approximately 90% success. You can have in the long-term problems with necrosis of the uterine muscle, and you have a failure rate, and you need to open the belly, actually, especially after spontaneous delivery. You want to avoid this. Another option is actually the ligature of the uterine artery. However, this needs a lot of experience. This needs a lot of experience here because you have to go into the retroperitoneum and you have here the risk for injuries of the ureter, for instance. Now, CELOX came on the field, and as Holger will present in his lecture, I do not want to say too much about this pioneer work from Bernd Schmidt and from Holger Maul and his team. And Professor Sade was also co-author in the initial publication 2013, which was published in the AJOC with 20 patients and the successful use of these gauze. However, it was not really recognized in the society because it was not approved for the obstetrical use, obviously, and therefore it was ignored for several years. Fantastic measure. This was the work here, and Professor Sade and Holger Maul and Schmidt published in the AJOC with these non-licensed, for obstetrics licensed package from the CELOX. Now, how we are using it. Since 2017, we have approximately 400 patients which were treated by the CELOX PPH, and I want to demonstrate here in this short video clips the real world. So this was a patient here with 24 weeks. She had a late abortion, and despite all medications and tranexamic acid, sulprostone, emptying the bladder and ruling out placental tissue and injuries, we went to the operating theater and we visualized by a pulse wave Doppler and by color Doppler the placenta bed bleeding into this uterine cavity, which did not stop to bleed. So in the next step, we grasped the anterior lip of the cervix after speculum and insertion, and you can see here, this is a young trainee in this after 2-month training in our hospital. This is the experienced consultant, and I have performed the ultrasound at the same time. And you can see here the regular packing of the uterine cavity with the gauze. So if you are careful, you cannot perforate the uterine cavity. You have to be careful when you have a patient after C-section and you wanted late bleeding. that you do not perforate through the uterotomy or hysterotomy scar, but normally, especially in patients with atony, it is very easy here to apply, and you can visualize the hyperechogenic layer of the gauze in the uterine cavity. And then we always collect the blood to make sure, because in 30% the blood loss is underestimated just by visual. And so it's always important to measure the amount of blood loss. So with this easy application under mostly regional or sometimes general anesthesia, I can show you here with this video from the company how the chitosan granulars act at the placental site.
CELOX PPH is a unique, fast-acting hemostatic gauze incorporating a patented chitosan derivative in the form of CELOX granules. At the site of bleeding, when the positively charged CELOX granules attract the negatively charged blood cells, they absorb fluid, swell, gel and concentrate platelets to form a robust mechanical gel-like clot that plugs the bleeding source. The CELOX PPH gauze exhibits a level of mucoadhesion to the surrounding tissue, which keeps the gel clot in place. By creating a physical barrier and through the activation of platelets, CELOX PPH stops the bleeding and reduces the risk of rebleed. Studies support that CELOX works independent of the body's natural clotting cascade and has been shown to work even in the presence of clotting dysfunction.
So this last sentence actually is one of the most important.
CELOX PPH.
But we compared actually a historical cohort where we used the balloon and compared it with the cohort afterwards where we used the CELOX tamponade and compared the results. And to make it short, I can show you that CELOX was excellent for the PPH treatment. We haven't seen any major adverse events, and it was especially particularly suitable for low uterine segment atony or placental bed bleeding and in patients with coagulopathy. So this is Youssef Bakri. He is a pretty good friend of mine, and I apologize actually that in the comparison between his balloon technique and the CELOX is really superior in our retrospective analysis, because it was much easier to apply and it never dislocated. I think we had in these 400 patients one lost the gauze due to severe coughing, and another lost it because unfortunately somebody pulled too early on the CELOX, which was lead out of the vagina. But normally the CELOX does never dislocate. We have less pain because the inflation of a balloon with 300 to 500 cc can lead to relatively strong pain, but with the tamponade, this is a painless measure, and we can use the CELOX also for lacerations in the birth canal, in the vagina, in the cervix, or at the perineum, which is not possible with the balloon. But the absolutely major difference is the hemostatic effect of the gauze at the bleeding site. So nowadays, we started with 24 hours. Nowadays, we are removing the gauze after 12 hours. And you can see here under ultrasound guidance how easy, without any analgesia, the gauze is removed. And you can see that there's no upcoming bleeding. And so the gauze looks like. It is easy to remove. It is with some blood, clot and gel superficially shows blood is showing on the superficial of the gauze, and you can see that we are putting sutures on the tip of the gauze to make sure that we really removed all parts. And then for further security measurement, we put an armband around the wrist of the patient. And this is a trick from Mahantesh Karoshi from London. He told me, if you ever put any foreign body into a maternal wound, you put an armband around, and only the one who is removing the gauze or the foreign body is allowed to remove the armband. And so you do never discharge a patient with a foreign body. Now you can see here the final abdominal view of the uterus. It's empty, and we haven't seen any recurrent bleeding after the removal of the gauze. We published some papers about our experiences. You can read in the Journal of Perinatal Medicine from 2022, where we showed that we severely reduced our hysterectomy rate, approximately 80%, after we started to use the chitosan covered gauze. And we also published case, and we have seen another patient or two further patients where we used a kind of a sandwich technique where we combined balloon with the CELOX tamponade. However, these are just exemptions. But here again, after the introduction of the CELOX, we reduced significantly the number of hysterectomies in comparison to the previous years. So interestingly, there are only a few reports in the literature so far. Here is one interesting report where colleagues described 4 different scenarios. One of the scenarios was that they used it in a patient intra-abdominally for packing. After hysterectomy, the patient was severely bleeding intra-abdominally, and they packed the whole abdomen in a kind of an off-label use. And the next day, they removed the gauzes, and the patient survived this severe bleeding situation. Now, I want to show you also 2-3 examples of our use during C-section. You can see here a patient after 2 previous C-sections. The uterine wall was totally fixed on the abdominal wall, and I was just able to open a little bit the fascia, and then I saw already a prolapse of the amnion sac in this patient, and I was really afraid to make more preparation there because of the bleeding, and therefore we pulled the baby out by a ventouse through this small hole, and this was uncomplicated. And after the closure of the uterotomy, it started to bleed relatively severe in this area of the repair, and I really no idea how to stop this bleeding. So I had an idea because we used the CELOX tamponade on this and put it 5 to 6 minutes on the wound with compression, and then we removed it again because you can't leave it in. It's not resorbable, and so you have always to remove the gauze when you use it intra-abdominally or extra-abdominally, actually, here in the superficial area of the rectus muscle. And as you can see here, the bleeding stopped. And obviously, this 5-minute compression with the chitosan was sufficient to make a gel-like clot. I checked the urinary bladder that there's no laceration, so we filled the bladder with some fluid. So again, another example, this is a patient with a lower uterine segment, placenta previa totalis, and you can see this extremely thinning of the lower uterine scar after one previous C-section. Here, this huge major placenta previa, the cervix was not invaded. And also by MRI, we were able to see this extremely thinning of the lower uterine segment. So we expected actually not a pass, not really a placenta accreta, but we expected a severe lower uterine segment atony in this patient. And we performed a C-section and inserted the uterus above the placental edge, delivered the baby, and then it started, then we visualized the placental side, and I removed the placenta from internally, actually. Then it started to bleed in the lower uterine segment severely, so we packed the uterus with 2 gauzes of chitosan, of the CELOX gauze, and let the end of the gauze through the cervix into the vagina. You have to be very careful not to suture the gauze when you close the uterotomy. It is described, and we also experienced in 2 patients that we stitched the gauze and that the gauze was fixed in the uterine cavity for the removal. So, but this was also successful, and we stopped the bleeding of this patient in this lower uterine segment. Now, just to give you an idea as an alternative, this is Professor B. Lynch demonstrating the B. Lynch 2 suture. This is a special suturing of the lower uterine segment. If you have no balloon or no CELOX available, you can try to stop the bleeding also surgically by going with the suture from outside to inside, inside, outside, and then the same thing on the other side. And the concept is actually to make kind of a ligation of the uterine artery in this lower uterine segment and to compress the lower uterine segment. The problem of this is some really surgical experience, and you have to be aware of bladder and ureter lesions.
Very satisfying. Cool.
Okay, now what happens when you try to remove a gauze and the assistant says, yes, I removed it, it was complete, and then the patient comes 3 months later with discharge and with this ultrasound finding. So this is a patient where in our hospital, the colleagues left half of the gauze in the uterine cavity, then discharged the patient. She came 3 months later and complained about, interestingly, without any fever, without any leukocyte increase, without C-reactive protein increase, but she had some discharge. And so we tried to remove it, and we removed the gauze. It was, in the meantime, not bloody. It was really clear. And then we found the suture at the end. So obviously, the removal was incomplete due to suturing after a C-section. So now I want to finalize actually with another indication area, and this is the indication of laceration. There was a patient, 29 years, 38 weeks, and she had a severe morbus Wellhoff, and she had only 30,000 platelets, and she received intravenous immunoglobulin. However, after spontaneous delivery, she developed a huge paravaginal hematoma on the left side, and we put a CELOX for 5 minutes, then primary closure of the wound, and she received contraction. Okay, good. I want just to show you that we had the bleeding in the vagina, and it was not able to do any interventional radiological embolization. So the only chance was really to pack again this vagina with CELOX and left it for a couple of hours in, and this was quite successful again. So Anna Dückelmann, she will present her results of the long term. She's doing a great job with all these publications, and the credit goes really mainly to her and to her students. And she now will submit in a couple of weeks, I think, a cohort of patients with lacerations in the vagina or in the cervix, and she showed in 20 patients with substantial blood loss because of birth injury, retrospectively, that it was extremely effective to use the gauze as well. So the average blood loss of these patients was 1.4 liter, and the tamponade was introduced between 20 minutes and 24 hours. And 25% of these patients required ICU treatment, 70% had regional anesthesia, and 30% general anesthesia. We haven't seen any postpartum fever or infection, and there was only one patient where the CELOX use was not successful, and this was in a patient where the gauze was applied 3 hours after delivery, so obviously too delayed application. So anyway, our conclusion also for the lacerations in the vaginal canal are that CELOX is proved to be safe and effective for the management of severe lacerations after vaginal birth, and shorter applications time may be sufficient for birth injuries in comparison to the uterine atony patients. Now you can read all this in our recently published paper in the AJOC. We published an expert review about all these, what I told you now in my short presentation, how we are using it, how easy it is to apply. And I come to the conclusion that for me, especially in comparison to the balloon and also to the relatively complicated and expensive suction devices, that CELOX is at the moment for me the winner, and it is useful, fast-acting, versatile, simply device to stop bleeding. Every midwife theoretically could take it in her pocket for also outpatient or out-clinical deliveries and home deliveries. We haven't seen major adverse events. It is particularly suitable for lower uterine segment atony, placental bed bleeding, and patients with congenital or acquired coagulopathy after heparin or aspirin treatment. It does work as not only as a tamponade by compression, but it is also the impregnated chitosan hemostatic agent, which supports the clot formation independent of the patient's coagulation. We used it after spontaneous deliveries. We use it during C-sections, implemented during the C-section in the uterine cavity, lead it out through the cervix. I have stopped bleeding of the cervix in vaginal traumas. We have used it also in patients with cervical cancer in the meantime, or sarcoma bleeding, and in patients with severe breast cancer bleeding. All these scenarios are now possible to treat with this treatment and with this CELOX tamponade. And I'm very thankful that CEO Russ Mapley, that I reached him several years ago and encouraged him to apply for the approval for the use in obstetrics, because for me, it will save in the future thousands of women's lives and thousands of women's collateral damage due to other necessary measures. So thank you very much for your attention.
Thank you, Professor. Very, very nice presentation. And I really want to highlight what you said earlier about the publication that was forgotten. So I'm glad you didn't forget it and you continued working on it, and now it's a reality. Thank you. It is really a great pleasure for me on a personal and professional level to introduce our next speaker, Professor Moll. First time I met Professor Moll was when he was still doing training and research, and he came to the University of Texas Medical Branch, where I was before moving to Virginia, and spent 2 years with us, was very productive in research, and he was the first to introduce me to CELOX. At the time, it was not named CELOX, I guess. And it's great to see that he's continued on his impact, and his career trajectory has been up and up. So he's currently the chair of obstetrics and gynecology at the Asklepios campus in Hamburg of the Semmelweis University, Budapest, Hungary. And he's a director of departments of obstetrics and gynecology at several Asklepios campuses. So, Holger, great to see you.
Yeah, thank you, George, for introducing me. It's a great honor to be in this round and to talk about CELOX and all the experience I made during the last 13 years. When we started CELOX 13 years ago, I would have never thought that we come to this point and that we can present data like this, and that we have a certified product that is available on the market. Let me go on. Let me find it. So I guess you see my presentation, yeah? This was in 2011. You see me a couple of kilos more on my belt, and next to me, Bernd Schmidt. He was working with me in the Marienkrankenhaus in Hamburg at that time. And we were young, we were brave, and Bernd came up with CELOX that he found on a YouTube video, and told me that this is something we should try on a PPH. And so we ordered it, we talked to the company that produced it at that time, and we thought maybe that's really something we could try. And we really we had a patient then where we knew that she wanted more than one child. We were short before doing a hysterectomy. We were able to talk to her during the operation, and we asked her, we have a new method. Would you allow us to try it? So she said, of course, please preserve my uterus. I would like to have more children. So we just dared to do it, and it was a very, very tense moment, as you can imagine, when we used it first. But it worked immediately. We were really astonished at that time, and it was absolutely fascinating. So we published this single case just to have something to rely on, and then because everybody was so fascinated by it working so well, we collected a couple of cases that we published a year later. You see, we had quite a big obstetric unit at the time with around 3,000 deliveries a year at that time. So it went rather quickly that using it, because all the colleagues also were like, oh, that's such a great method. Let's just do it because it's very, very helpful. And this ended up very soon in the up-to-date review. So it was internationally cited in this very important network. It's a review written by Mike Belfort. He obviously read our paper in the American Journal. And so that gave us some backup, and it was very helpful for us to have this being protected to some point by these international citations and publications, because of course it was not certified for use in PPH at that time. You heard a lot about it, and now in the meantime, so I don't need to talk too much about it, but these were the typical olive green packages that were available then in a lot of obstetric units in Germany, because we talked about it and we presented it and we presented our results. Like, for example, here about the first 2 years after introduction, we just showed how the rate of hysterectomies, peripartum hysterectomies, went down. As Wolfgang already showed in his talk, we had an almost 2-year period without hysterectomy later on, almost 2 years. So because that's a 4-year period, and we had 6 hysterectomies, 7% despite the use of CELOX. Those were atony after vacuum, a uterine rupture. It was a severe rupture where we just thought it's not going to work, so just do the hysterectomy. Then a severe preeclampsia, atony after a secondary C-section, severe hypertension in a twin pregnancy with a huge uterus. And one case I will never forget was a severe ITP, immunothrombocytopenia with only 2,000 thrombocytes, and a placenta previa totalis in a patient where we left it for 48 hours. That's the only patient where I left CELOX for 48 hours, because we tried to increase the count, the thrombocyte count, but with anything we had, but in the end it didn't work. And so we took it out after 2 days in the surgical department, and unfortunately she started bleeding again, so we hysterectomized her. But those were the few cases, and you just by looking at it, you see how it went down. So we had a significant reduction to 28%, so 70%, over 70% reduction. And as Wolfgang told you, he had an 80% reduction. So it's almost the same. And the longest periods without postpartum hysterectomy after introduction of CELOX was almost 2 years. You can imagine how sad we were when we had this hysterectomy after 23.5 months, so only 2 weeks left, and we would have a 2-year period in a quite a large obstetric department. We published those data in 2017, 101 cases with CELOX. And in that meantime, because I gave many talks on the issue, more than 60 to 80% of the obstetric units in Germany used CELOX, so the non-certified product already, because I got a lot of calls from people around Germany who said, "Oh, it's really a great idea. I didn't dare to use it, but we were in such a mess here with the patient, so I used it, and it's really impressive." Experience with around 2,000 cases in about 13 years. I just counted it and just got my data, and it's around 2,000 cases. And I was very happy when Russ and Andy came up at the DGGD meeting in 2022, and they showed me the first package of CELOX PPH due to all the work of Wolfgang Henrich and his team, because that's a really great thing that this Charité took up on the project and published all these valuable data that made it possible to get a certified product. So at this point, thank you, Wolfgang, for all your work, and this is really a great issue. Now, as I saw already in the chat, there are a lot of questions that I try to answer now. First of all, if you use it clinically, just to share my experience with it, always use antibiotics. While CELOX is in situ, we always use IV antibiotics, and please measure temperature regularly to exclude fever. I think that it's important. Maybe it's even possible to not use antibiotics, but I personally would never do so. Of course, try to work as aseptic as possible. So when you insert it vaginally, try not to forget to disinfect vulva and vagina. I know how stressful it is sometimes, and then all the things are done at the same time, but try not to forget to disinfect vulva and vagina, because you may transfer gut bacteria upwards into the uterine cavity that you don't want to have there. That is normal, that you count the upper limit of measurement. So don't be worried about that. It's absolutely normal. Also, we usually combine CELOX with uretonics. It's usual that we do it. It would be an exception if we don't do it. And please don't stop uretonics before removal. I just had a meeting 2 weeks ago when I had to leave the meeting, my own online meeting, because we had to hysterectomize a patient late night. It just happened because we removed the uretonics too early while CELOX was in situ, and in the end, that was the mistake. So don't stop uretonics. And we stop the uretonics usually 2 hours after removal and after making sure that there's no bleeding. It doesn't make sense to stop it earlier, you know. Why? Yeah. Then in cesarean section, we always start with B-Lynch, and then we insert the gauze. Yeah. We then compress the uterus with the gauze, and we tighten the node. Yeah. We never do B-Lynch after we inserted the CELOX. If we already have CELOX in situ, then we would do pereira stitches to avoid stitching through the gauze. And while inserting, never forget you need to get it out somehow, because sometimes, especially at the beginning, we had colleagues who just put it in somehow, and then when it was in, they closed the abdomen. Please don't forget the gauze actually is off it. Usually so that it's painful. Of course, if you then she gets nervous, yeah, and I'll pull it out. It's never immediately long. Can't bear it. Really, if you need more, and the most I used was 4 gauzes. It's very rare case, but sometimes you have a woman with a huge uterus, and for example, after a twin pregnancy or something, it's a huge cavity. You need to CELOX in. You may need to use 4 gauzes. that's absolutely rare. It's not based on the CELOX and the recommendations, but that's why I note it's off-label, yeah, and we sew them together. I know that there are some people putting them aside, so put two gauzes and then put them aside. I don't have experience with that. I never did that. I always just take a Vicryl and sew them together. It's never a problem. I never saw a problem. It's very difficult. It's holding very well, and you can extract it very well. Don't leave it for more than 24 hours. I told you that I have one patient for 48 hours out of certain reasons. I only have this one case of experience, but I don't leave it more than 24 hours. Wolfgang just showed you 12 hours. From my experience, 12 hours usually is absolutely correct. But you know, sometimes you have a situation, you put it in, like on a Sunday morning, and then the whole team is still, the staff is not everybody's here on the team. You don't have the best situation. I don't have a problem with leaving it 24 hours and even a little bit longer if it's necessary to have a full set of people around, the team complete, anesthesia and whomever you need in certain situations. But still take it out as soon as this is possible. I know this Andy and Russ may not love to see that picture, but that's why note it's off-label. You can, in certain situations, you can cut smaller pieces in case of first and second trimester bleeding, where we also use it, or you can fold it longitudinally, as I showed here on the right side. You can fold it to get it through the cervix if you have a very small cervical canal, or if you've done a C-section, a primary C-section with a small cervical canal, and then she started to bleed, like, let's say 1 or 2 hours later, and you want to try to get it through the cervix up into the uterus, then it may be necessary to cut smaller pieces and to get it up, or fold it to get the gauze through the cervical canal. So I do that, and that's my personal experience. It's important if you put it in vaginally, because the gauze, CELOX PPH, is quite soft, but the classical CELOX is a little bit rougher. To avoid sharp margins, I need the gauze longitudinally, so it's a little bit softer, or I drill it, and then I put it in. So by that, you don't have sharp margins that may saw into your vaginal wall or your cervical wall. I saw lacerations of the cervix. I saw lacerations of the vagina in others doing that, because I didn't think they did it the right way. If you see it sawing, just knead it a little bit, drill it a little bit, and then you don't have this problem, and nothing at all happens. Be aware, and Wolfgang already showed some pictures, that even if you remove CELOX, the echogenicity of the uterine cavity is very much increased. Yeah, you see the remnants of the chitosan granula. They give a big echo, and don't be nervous about that. You don't need to do a curettage or anything. Just leave it where it is. It's anyway biologically degradable. It will disappear, but it can be, the echogenicity stays for a couple of days. Yeah, it's nothing that should make you nervous. Be aware that pelvic packing can be helpful in addition to intrauterine CELOX in severe cases. Of course, for that, we don't use CELOX in that situation. We have CELOX inside the uterus, but intra-abdominally, we do pelvic packing, especially in very difficult situations where you have an unexperienced team. They are not able to hysterectomize. They are very worried about doing further surgery. You don't have the perfect setting, or you would like to transfer a patient from one hospital to the other hospital. Then it's maybe very helpful. You pack the uterus, you close the uterus, and then in addition, you put like 2 gauzes behind the uterus, behind the ligamental lata, and you take another couple of course moistened gauzes in front of the uterus, and you pack it, and then you just close the fascia and try to then transfer the patient, or leave it, and reopen the patient the other day. You can also do embolization in that situation. I did it a couple of times that we were not able to do any further surgery. We didn't know how to save the patient at that situation. So we packed her, and then inside the uterus, out of the uterus, and then we did embolization, and then we took all the packages out on the next day. Yeah, that may really save lives. And then, of course, ultima ratio, always hysterectomy. Sorry, misspelled. IE, German is wrong, just an Y, of course. And I do hysterectomies now with CELOX in situ in the sandwich technique. This I did it. The first video here on September 22 was a fourth para. She had 3 sections, C-cesarean section in her history, and it was a placenta previa percreta. And we at the beginning we thought we could save her and save the uterus, and later on we decided to hysterectomize. You don't need to remove. You don't need to remove the B-Lynch suture. You don't need to remove the CELOX. Just leave it where it is. It's much easier for the preparation of the bladder. It's much easier for the preparation of the broad ligaments, and because you can easily feel where the gauze is, you can have a better impression of the uterine wall, and you can easily then hysterectomize her, and you will see that I just take out the gauze from the vagina. It's a low supracervical hysterectomy. I just pull the cervix out from the vagina where it is, and you see the uterus is still packed. You still see that. You see that I'm very happy. Yeah. I was very happy that it worked so well. And this is how it looks like. You see the B-Lynch, you see the Pereira stitches, and then you see the CELOX inside hanging out from the lower uterine segment, and the cervix stayed in situ. So that's a very good technique that I would recommend to you. And this is a Jehovah's Witness, a third para, in January 23, a history of 1 C-section. It was a placenta previa percreta. And in that situation, I saw that she's bleeding behind the CELOX, so there's a coagulum. And you see also B-Lynch sutures, CELOX here in the uterus. And in that case, I decided to hysterectomize her because I knew that I was not able to give any concentrates, blood packs. So I decided to hysterectomize her rather early, because I knew that I'm gonna go into trouble if I don't do that in an early stage. Yeah, that's my experience with CELOX. You can contact me via email. You can contact me via LinkedIn, where I'm very active, or via Instagram if you have further questions. I'm more than willing to share all the information I have from 13 years of experience. I hope we have a nice discussion later on after the next talk. Thank you for your attention.
Thank you, Holger. It's great to see your extensive experience and the positive results that you've seen. Our final speaker is Dr. Duckelman. She's the senior physician at the Department of Obstetrics Campus Virtual Clinic Charité Hospital in Berlin. Dr. Duckelman.
So it's a great pleasure and honor for me too that I take part in this expert forum symposium. I'm talking about the long-term surveillance of CELOX PPH. And yes, we have to take into account the rising incidence of PPH. Professor Sade already talked about it. We have women dying every hour, and we have to try to find a successful PPH therapy working really worldwide in low and high-income countries. What are the requirements to a PPH therapy? We have to take into account the health system in the country, and we have to accept the prerequisites. What we need is a really safe therapy, a successful therapy, with a very high training curve. Time factor is very important. So, I mean, it is easy to apply, very fast, doesn't take much time. and the costs are acceptable. So what do we need for PPH therapy? We need an effective therapy. I may present our last details of our whole PPH cases. As Professor Henry said, we have almost 400. We have an overall success of 92% in all cases, even the most severe ones. We have in a mild one, we have 100% success rate. Most severe PPH cases with 5. What is also issue? Professor Henrich already talked about that we may reduce the rate of the hysterectomy. Another important point is the training. As I said, the learning curve is very high. It's very easy. Even a young assistant may only see one, and then she or he is able to use it already. Time factor, very important. So you only need, let's say, 1 minute to apply the gauze, and also the costs are acceptable and much cheaper than other comparable devices for PPH therapy. The biggest issue is safety. That's why already in our first paper back in 2019, we checked for safety issues, and we compared two groups, the Bakri balloon group and the CELOX group. We saw an easy application. There was no dislocation. The pain was less. And especially, Professor Maul already talked about it, the CRP, which is of course high after a bleeding event and after application of an intrauterine device, was lower when compared to Bakri balloon group. Our recent paper published this year was about the short and long-term menstrual, reproductive, and mental health outcomes after the use of CELOX, again compared with the Bakri balloon group. We included in total 260 patients. We had a short-term follow-up of 214 in the CELOX group and 46 in the Bakri group. The low number of the balloon group was because, as Professor Heinrich already said, we stopped to use the balloon since several years, so we only have a lower number of patients with the balloon. We have a long-term follow-up of 71 patients in the CELOX group. So the blood loss was comparable between the two groups, but we saw no difference in hospital stay, no difference in fever or inflammation parameters between the two groups. So as you can see here, only 5% of patients had fever postpartum. The leukocytes were, of course, elevated, but only until the maximum 15, on average 15,000 leukocytes. We had, of course, low hemoglobin values and a CRP an average of 86. There were quite a lot of questions already about the removal of the CELOX tamponade, which is very easy, as I already said. You see it very nicely in the ultrasound, so there's absolutely no problem because of the hyperechogenicity of the tamponade to see it. And it is easy to remove. We had no problems in all our cases to remove, except of one case where the gauze was sutured into the uterine wall during a C-section. What about later on in the short-term follow-up? We do now a prospective study since 9 months, post-approval study. We include all our patients having had a CELOX tamponade, and we do a control in every patient after 6 weeks after birth. So far, we have included 20 women who had no complaints at all, no problems in the course of these 6 weeks, no fever, no serious adverse events. And as Professor Maul already explained, still after 6 weeks, you may see some granulars, still a little bit hyperechogenic, even after such such a long period of time, but there are, as I said, no complaints at all of the patients. Interestingly, we had one patient with a uterus T. delphis, and there was a suspicion of placenta, of arrest of placenta in one cavum. So the gynecologist who is treating the patient wanted that we do a hysteroscopy to exclude or confirm the placenta. That these are these pictures of the hysteroscopy. We have found some placenta tissue, and we did, of course, a histological analysis of our curettage later on. And in the histological analysis, we did not see any part of CELOX in the curettage. Only placenta was confirmed. So what is about the long-term follow-up after the application of CELOX? There was no effect on the endometrium, and we saw no difference in cycle regularity, in duration, in menstrual flow or dysmenorrhea. The rate of breastfeeding mothers and the duration of lactation was also the same between the two groups, CELOX and balloon tamponade. 89% of our patients had a regular cycle after the use of CELOX. We saw normal, we had 80% had a regular cycle. Well, we have to take into account that the women are still breastfeeding, so this may explain the cycle irregularity. The duration did not differ between the two groups, and also the menstrual flow was the same. Now we wanted to know about the gynecological problems. There was, as I said, no adverse events, and we have a time period of 26 months after the bleeding event. There were no complaints associated with the intrauterine device, and there was a high satisfaction rate of 85–86% in both groups. The only dissatisfaction was discomfort during the stay at the postnatal ward and some communication issues. Of course, sometimes it is difficult with the patient lying on the intensive care unit and the partner in another building to organize all this communication, but we're getting better every day. What about the mental health issues? After a bleeding event, we saw no differences in the impact event scale between the balloon and the CELOX tamponade groups. Interestingly, there was no impact of severity of PPH on mental health. So the mental health did not depend on the amount of blood loss. It was only the event, the experience of the event itself, who had an impact on mental health. Also, another interesting finding from our point of view was that quite a low rate of patients after this bleeding event had still child wish for a second pregnancy. Only 27% in the CELOX and 29% in the balloon group wanted to have another child. There was even one termination of pregnancy because of anxiety. What about the reproductive possibilities after the use of CELOX? All our women having child wish had 100% success rate for getting pregnant. In total, so far until the year 23, we had 29 pregnancies. We had 19 term deliveries, true preterm deliveries. Out of these, 4 had again a PPH, so a postpartum hemorrhage. 2 of them received again a CELOX tamponade. We had 4 ongoing pregnancies at the time of the survey, 3 early miscarriages, and 1 top, as I already said. So as a conclusion, we can say that CELOX PPH is a safe method to stop PPH, with really no negative impacts so far on gynecological and mental health outcomes or subsequent fertility. There was no elevated infection risk in the short and long term. It's fast acting, it's really safe, it's clinically effective, it's easy to use, so it's really a game changer in PPH therapy.
Thank you
Thank
so
you
much
for
for sharing this practical information and for the reassuring data that you shared with us. I'll now turn it to Andy to go over some questions. I know we're short on time, so we'll try to get as many questions as we can. Andy?
Thank you, Professor Sade. Thank you to all our speakers, some fantastic presentations there. I think we've had a number of questions that have come up in the Q&A, and I've noticed some of you have answered some of those questions directly. Maybe first of all, Professor Henrik, you've answered some. Is there anything particular you want to pick up on where you've started to answer and you want to follow up with a more detailed discussion? Otherwise, I can run through some of the questions.
Yeah, at first I would like to thank you and all the speakers and our moderator for this excellent data. There was some new for me as well, especially from Holger. But one thing, just to make a comment, Holger, you said that you would perform during C-sections always a B-Lynch suture before you are using the Chitosan in atony uteri. From our experience, it is not necessary, and we are going actually straightforward with the gauze and then close immediately under sulprostone and tranexamic acid. And the second thing, what we do in another way, we do not continue uterotonic IV intravenously over the time of the removal of the gauze. I'm very careful, especially with sulprostone. I have seen, especially after the second or third ampoule, I have seen severe lung edema. So from my experiences, that normally you should need only one ampoule of sulprostone over 5 hours and then stop that. And maybe you can continue with low dose oxytocin till the next day to the time of removal, but we do not extend the sulprostone administration more than one ampoule. And the second thing is we do not continue high dose oxytocin over the time of removal and even not longer, because we never saw any rebleed. So was really interesting. When we had an unsuccessful initial treatment where one gauze, for instance, was not sufficient, we removed sometimes one gauze and then packed with 2 further new gauzes, because you need the combination of pressure and the clotting activity of the Chitosan. So therefore, sometimes the failures from my side and experience are that if you have an ongoing bleeding with one gauze, it's just not sufficiently packed. So these are just 2-3 comments on your excellent presentation, but in these things, I would not follow your recommendation to do a suture necessarily before the application of the Chitosan.
Yeah, thanks for your comment. It's just how I do it. I mean, I don't do of course, I also don't do a B-Lynch if I insert it vaginally after vaginal birth. So you may be right, but if I'm in the situation that I have a severe bleeding and I decide to insert CELOX, then for me it's conclusive to use the classical methods first and then add the CELOX. So that's my way of thinking. But you may be totally right. That you do it that way. I would have a problem not doing it if the abdomen is open anyways, because I think that the compression from outside, that this also helps, because I'm always worried that it bleeds behind the gauze. That's what I'm always worried about, and that's why I personally have a problem also with reducing or taking out the urotonics too early, because for me it doesn't make a big difference. We have a 12-hour interval with urotonics. If I do it for 2 more hours or not, for me it's not a big deal,
But trust me, it's not necessary. If you remove it and you have no bleeding and you have an empty cavity and you have no bleed, you do not need further utrotonics. I would just
It
try
may
to
be the case.
try
It may be the case, but you know, I'm still worried. So, so
Have
I'm
you seen?
maybe
Have
a
you
little
seen
bit
a
more
rebleed?
cautious,
Have you seen a
overcautious.
Have you ever seen a rebleed when it was stable for, let's say, 2 hours or 6 hours? Have you ever
No,
seen a rebleed?
because probably because I did it like that before.
Yeah, but
Why
we didn't, and we had the same success.
So we'd like to get more questions, but
Yeah, okay,
Andy, this brings up a good
It's
point.
really interesting debate and discussion. We've got a kind of similar question, but it's kind of repeated 3 times. But the question is around how do you know when bleeding has stopped? When would you recommend to remove the gauze? Similar question about how do you decide when to pull out the tamponade? And also a question around is it possible to put the CELOX in to the uterus during a C-section and then pull it out through the vagina after, for example, 12 hours. So question really on timings, how long you would leave it in, and what are you looking for in the patient to determine that you've achieved hemostasis?
I mean, we started with 24 hours because this was the recommendation for the balloon tamponade, and this was we wanted to compare the results between balloon and the CELOX, and so we decided, okay, when the balloon is 24 hours, let's leave the CELOX also 24 hours in. But in the meantime of our experience, we became more and more encouraged to reduce the duration of the foreign body. And so we decided from one day to the other to let's try it after 12 hours. And if she would start to bleed again, we put another in. So we started to remove it after 12 hours. We try not to remove it at night at 4 where nobody is on call. So we try always to look, is it in the morning hours where we have enough stuff, if there's any complications, but we haven't seen any complication. And therefore, I think we can be more encouraged to remove it already after 12 hours because we should not be, because we recognized, and this should be mentioned also, we recognized in 1 to 2% from 400, we have 4 patients which showed some kind of a visual disorder or some dizziness, some neurological signs where we are not sure where this should come from. In 1%, 4 patients from 400. And when we looked to the other medications, for instance, tranexamic acid, if you look to the contraindication and side effects of tranexamic acid, you find exactly these visual problems, these hearing problems, and these mild neurologic signs, I would say symptoms. We had in these patients even done MRI imaging, CT imaging, we did liquopuncturing, we didn't find anything. We sent them to the nose and throat doctor, to the eye doctor, they didn't find anything. And after 2-3 days, the symptoms get resolved. There are some notes from German colleagues who are using the CELOX, and it appears 1 in a year in a hospital, or maybe every 2 or 3 years. But you should be aware of this theoretical reaction where we do not know really if it is related really due to CELOX, or is it the combination with tranexamic acid or other drugs. If you look to Nalador, sulprostone, all these drugs have all these side effects, and therefore it is very difficult to discriminate. But fortunately, these symptoms all get resolved. And if you compare other measures like embolization, hysterectomy, mass transfusion, or even balloon, which can rupture the uterine wall and can be found in the abdominal cavity, there is no method without any 100% non-side effect or non-theoretically small amount of complication. Even suturing, you can suture the bladder or the ureter by Berlin suture, etc. So all the things you do in medicine in these high-risk patients have some theoretically collateral damage. So far, this is the only thing what we recognized in more than 400 uses in 4 patients, but we are aware of this problem. And this was also one of the decisions for us to reduce the duration of the packing. So to go to 12 hours, maybe we might be able to remove it after 6 hours. But
sure.
we have to get more data. We have to collect more experiences, and hopefully people from the audience, from these 200 listening to us, who may start and make their experience and hopefully publish their experience to get more information, and especially also to convince the WHO and FIGO and so on to implement this simple device into the guidelines. Because every day where we do not convince the opinion leaders from these huge organizations are days where we lose mothers' lives and have a lot of collateral damage.
Thank you, Professor, for this sobering comment, and I agree with you. The alternative of the side effects is mortality. I think I'll take side effects any day. Thank you.
Okay, so we've got a common question that's come up about tears and lacerations, and will it be available in different sizes? I'll answer from a commercial perspective that yes, we are developing a smaller option that will be more cost effective, will work in exactly the same way as CELOX PPH, and we're looking at that within the next 6 to 7 months. But the question I'd like to ask the panel here is, what experience do you have of using it in tears, lacerations, diffuse bleeding, episiotomies, etc., and what kind of success have you had in using it in those situations? So maybe start with Professor Moore. Do you want to answer that first, and then we can move through the panel?
Now, you asked me, yeah? I didn't, yeah. For the vaginal,
first, absolutely fine.
For the vaginal lacerations, well, there is not only vaginal, but also a paraclitoral, labial, perineal. We have quite a lot of lacerations, and we have so far collected, as Professor Henrich pointed it out, 20 patients with a really severe loss, blood loss of sometimes 2 liters. And well, we simply cut the tamponade and applied only 1 meter or so. It's fairly enough. And well, the bleeding stops immediately within 2 or 3 minutes. So we have never, in our success cases, you see this immediately. In our success cases, we have never had another bleeding after these 2 or 3 minutes. In none of these cases. Of course, we have unsuccessful cases, but then it's bleeding. There's a continuous, well, not in the vaginal use, but in the intrauterine use. For instance, as also Professor Paul Maul pointed it out, if there's an uterine rupture or so, well, you can't, or especially in lacerations of the arteria uterina, sometimes it's not so easy to see first, and then we have applied the CELOX and it didn't work because there was this bleeding of the arteria uterina, and then, well, you have this continuous bleeding. But if the bleeding stops, it will not bleed again. That's why we think about the removal after 6 hours, because it's justified from my point of view.
Thank you, Anna. I'll just go to another quick question so we can move on. The question about embolization, embolism, not embolization, but embolism, thromboembolism. Do you have any experience of any cases where you've seen embolism, Professor Moore?
No. And also, this was a very important issue when we used it the first time, because when it was certified as a medical product class 3. There were also already extensive research done on exactly this issue. If it does distant thrombosis and thromboembolism, and it doesn't. So even the first CELOX product that was introduced around 20 years ago showed that there were no distant thrombosis and emboli, and that was also the reason why we dared to use it in that situation, and we never saw it, never had a problem with that.
Thank you, Professor Moore. And just a final question before we go to some closing poll questions. Professor Henry, just regarding placenta previa, placenta accreta or increta, do you have any guidance or advice or recommendations for how you would use the product in those scenarios? I know you've answered some questions on the chat, but maybe expand on that.
Actually, Anna is doing now an analysis of this subgroup of patients with Previa and PAS. And she can get into the details better than me, because she showed that obviously, especially placenta previa is even more risk factor than placenta accreta, because the placenta accreta without placenta previa seems to be not such a problem, because you can resect the lower uterine segment above the cervix, and you can stop the bleeding just by suturing. But if you have a severe placenta bed bleeding with accreta, again with combination of previa, then you have a problem, and then you might have also a problem, especially when it is more than adherent or accreta, especially in increta or even in pacreta, you have to solve that problem surgically. So I would summarize in that you can try to stop the bleeding after in patients with placenta previa, adherent accreta, when you act very quickly, when you give enough pressure to the placenta bedside, and when you close the uterus quickly with a lot of sulprostone and tranexamic acid, etc., pp. However, you might have in these patients some failure rates. So the most important use is, and the best use is, in atony and in birth canal lacerations, and as maybe a combination measure with sutures or with the resection of lower uterine segment placentally invaded areas. In patients with placenta pacreta, for instance, you have to solve the problem surgically. Resection, leaving the placenta in, or C-section hysterectomy without touching the placenta. So this is a very, very special issue. But fortunately, these patients are not the majority of the patients with life-threatening bleeding, because the majority of life-threatening bleedings occur in atony patients, especially in the lower middle-income countries, where the rates of C-sections are very, very low, and therefore they don't have these placenta accreta spectrum patients. So this is another special lecture, actually, to talk about in detail in which individual patient the chitosan may be in combination with resection, may be in combination with sandwich technique with balloon or embolization, might be helpful. But important is for an obstetrician to know all the different measures, the different methods, and then take the right method for the right patients. It's difficult to make it schematic. You have to think in some ways still individual.
Thank you, Professor Henrik. Now, there's been a couple of questions on shellfish allergy. From a technical perspective, we will point out, and I'll reiterate comments that Andrew Hogarth mentioned at the beginning around the way that the chitosan is processed. We remove all the soft fleshy part of the shrimp, which is the tropomyosin, which can give rise or has a link to shellfish allergy. In all the time we've been using it over the last 18 years across trauma and PPH, we haven't had a single adverse reaction relating to shellfish allergy. But I'll just do a quick fire to the group here and the faculty to ask if they have had any adverse reactions that they think have been derived from shellfish allergy. So, Professor Henrik, in a word.
No, we haven't seen, the allergy comes from the meat of the shellfishes, and the chitosan comes from the shell. So this was described in our first lecture, very good from our colleague. And so this is interestingly very often a question, but I haven't seen one patient with a severe allergic reaction.
Thank you, Professor Henrik. Professor Moore?
Same to me. I can just confirm what Wolfgang Henrik said. We saw some of the reactions that he described with the visual problems and the eye and the ear problems, but it's very rare, and I don't think it has anything to do with the allergy.
There's one interesting question about the Asherman syndrome. So I have one slide in my presentation actually, which shows that in China, the colleagues are using chitosan to prevent Asherman syndrome after hysteroscopic adhesiolysis. So obviously chitosan is anti-adhesive, does not make Asherman, does not make adhesions, and is antimicrobiotic. So, and this is the reason why we didn't see endometritis or infections in the uterine cavity. So don't be aware. And also the follow-up studies from Anna showed that we saw normal menstrual cycles, normal pregnancies. So don't be aware of Asherman syndrome. Remember, you put intrauterine devices for contraception into a uterus for 5 years. And you do not have normally Asherman syndrome after removal of an IUD. So why should you get such Asherman syndrome due to a gauze which you leave 12 hours in the uterine cavity? And you have a high recovery of the uterine cavity every month during every menstrual cycle. And so therefore we didn't see any Asherman syndrome.
Thank you, Professor Henrik. I think we're out of time. So I think at this point, we'll close the session. First of all, thank you to the distinguished faculty for making this event possible, and to the many delegates around the world that have dialed in today. There is, again, thank you very much to Professor Sade, Professor Moore, Professor Henrik, and Dr. Duckelman for the great presentations and the time for delivering on this key symposia. Any final words, Professor Sade, as our moderator and chair?
I want to congratulate all the speakers on bringing to us their experience. They're very supportive, experience positive, and I hope we can do more studies with CELOX, but I believe it is helping save lives and improve long-term health outcomes. And thank you to CELOX Medical for organizing and putting this this seminar together.
Thank you very much. Thank you very much to all our faculty and guests. I'll leave the poll up on the screen for a period of time. If you could just click some of the answers today, that will give us a little bit more insight and how we divert our research and development resources as we move forward. Thank you again, and have a great evening, everyone.